Thank you so much. I apologize for this. It's funny. Despite so many advancements, we still have not figured out how one person can be in more than one spot at the same time. Hopefully, by next meeting, we'll do that. Okay. So I'll be presenting on post-refractive surgery ectasia. I did notice that there is another speaker in this session who's going to speak on the same topic. So we'll try and not come too much in each other's way. I don't have any financial disclosures relevant to this topic. Just briefly, the incidence of post-LASIK ectasia is low. So 0.04 to 0.6%. But we don't know whether that is low or it's underreported. Folks who work in tertiary care hospitals, they probably would end up seeing more patients. Folks who live in areas that had more RK patients or LASIK patients with the microkeratomes that used to be 200 microns, they'll see ectasia. About 50% of cases, they present within 1 year. It's, of course, a devastating complication. You started with a patient who's 20/20, is not 20/20 anymore. LASIK is still most common, PRK, very few case reports, but it can still happen. SMILE, we have a few case reports, but we still have to wait and watch. We should probably give a good 10 years and enough cases before we start seeing any complications of that sort. Interestingly, post-LASIK ectasia is similar to keratoconus histopathologically. There are breaks in Bowman's membrane. There's slippage in the interfibrillar lamella of the cornea, and there are interlamellar clefts that can be large. Risk factors, the number one risk factor is abnormal corneal topography. So as the previous speaker very nicely and eloquently told you, if you see red flags, it's an elective procedure, let go of the patient, don't do it. Other lesser risk factors, less prominent risk factors are younger age, residual stromal bed thickness, which is really less than what you want it to be. And we have this PTA, percentage tissue alteration software that was described ages ago by Rendelman. High myopia or thickness, less thickness, residual bed thickness, they're pretty much the same. Enhancements are one risk factor that are sort of undermined. So when you see patients with unilateral ectasia who had surgery 20 years ago, ask them again if they had any touch-up procedures in that eye. And most likely they'll tell you, oh yeah, this eye they had to go back in and do some more laser. So as I said, asymmetry in corneal topography is the number one risk factor. You can have chronic eye rubbing, family history of keratoconus. We definitely ask about any family history. If there's a positive family history, you really have to tell the patient that there is a possibility, although you really can't say that it's really going to happen. Unstable refraction sort of goes hand in hand with the young age. Clinical presentation, progressive increase in myopia. That can happen with cataract as well, so you got to be careful. It might not be post-LASIK ectasia. You can have irregular astigmatism, loss of CDVA. This is really important. The most important thing is you see progressive asymmetric inferior steepening of the cornea, and you do see corneal aberrations, which makes our lives a little easier because we have a way to measure both these qualities easily on Pentacam, other corneal topographers, and things as such. I just want to let you know, the range of the disease is quite a bit. This is a patient who presented with mild astigmatism and blurriness of vision in one eye, and the other eye was normal. And when I did a pentacam, you basically saw ectasia. And patient was really surprised, and he had no idea what ectasia is. On the other hand, I saw a patient with first presentation with corneal eye drops in post-LASIK ectasia. So this is a patient who was a LASIK flap, has post-LASIK ectasia in both eyes, and this is her first presentation. So presenting with eye drops. So that's a range of presentation sometimes. The patient did well just with the observation and medical management. So you really can't be vigilant enough. This is a patient who is a physician. 2008, he had blurriness of vision, was diagnosed with ectasia. This is 2008, United States of America. Cross-linking was still not approved. Good vision, patient opted to observe. This eye had a touch-up and an enhancement. Other eye was normal. Fast forward 2 years, there was some increase in steepening. Patient still wanted to observe. Still 2010, he was asked to go to Canada that had cross-linking. Another 2 years, more steepening, more reduction in CDVA. Another 4 years, the patient was still wanted to observe. In 2019, where we actually told the patient that you're going to lose your corneal thickness if you wait more. And that's when the patient decided to have cross-linking. So you see, if you follow these patients serially, and this patient, sorry, I should have mentioned that the birthday is 1955. So all the population-based studies that show that keratoconus will slow down or possibly stop progressing when you touch 40 or so, that doesn't stand true for post-refractive surgery ectasia. Patient born in 1955 was followed from 2008 to 2019 and had continued progression. So that tells us that when you see these patients, you can tell them that you will most likely need an intervention. Another patient, 68 years old, LASIK done in 1999, progressive worsening, had bilateral pseudophakia, YAC cap was done, treated for dry eyes, lid tightening was done. Finally, it was sent to us because the patient was not seeing better. We did a pentacam and we saw post-LASIK ectasia. This is a 68-year-old patient. So really, you can see these patients even later in life. We did a contact lens trial. The visual acuity improved to 20/30. The patient was very happy. But 10 months later, the patient presented with progression. Again, 68 years old. So ultimately, we performed a cross-linking. Management options for for post-LASIK ectasia are contact lenses. You need to have very good contact lens person working in your clinic, and patient has to be motivated. Cost is a factor, but you can avoid surgery in many patients. Collagen cross-linking, as I'll discuss briefly, and of course, for advanced cases, you can do a transplant. Briefly, advantages, as I mentioned, is an excellent contact lens fitting is an excellent non-surgical option. It does not preclude any further surgery in future. Of course, you need an expert, and it's usually expensive. And basically, there are so many contact lenses that are available within India and outside of India that no patient basically exists that cannot be fitted. No cone exists that cannot be fitted because we have customized contact lenses. Collagen cross-linking. I just came from a session where collagen cross-linking was discussed for post-LASIK ectasia. Pretty sure everybody knows we remove the epithelium. We soak the cornea with riboflavin, use UV light for 30 minutes, put a bandage contact lens, and cross-linking is done. There is a clear shift in corneal biomechanics. That is what you're looking for in cross-linking. Relatively easier procedure, relatively inexpensive compared to contact lenses, and transplant follow-ups are not needed. I'm not going to discuss the types of cross-linking. We still try and do conventional cross-linking, the original Dresden protocol, where you take off the epithelium, soak the cornea for 30 minutes, and use UV light for 30 minutes. You can change your protocol, use accelerated cross-linking. You can leave the epi on if you want to, but we still do conventional epithelium off. Example, 52-year-old patient. You see, all patients that I presented are more than 50 or so. LASIK done in 2003, approximate myopia was high, minus 975. Visual acuity at presentation was 20/70 and 20/30. Saw this patient, told them they have likely ectasia. So we did the cross-linking. I always tell my fellows, you have to mind the flap. You really can't be careless with the flap. It might come off when you're removing the epithelium. That's why we use alcohol delamination. We use 20% alcohol, and the epithelium comes off very easily. And you can expect diffuse lamellar keratitis even after so many years. So you have to use steroids. You can use fluoromethanol or methanol or lodipred, but you don't need to use prednisolone really. So this is pre-cross-linking, and you see even 3 months down the line, you can see some flattening in this patient after cross-linking. So basically, at 6 weeks, the acuity was 20/70. It changed to 20/60. In 3 months, 20/50. 6 months, 20/50. And with refraction, not contact lenses, the patient could be improved to 20/20. Last option, corneal transplantation. Nowadays, everybody tries to avoid that if you can. Risk of rejection, infection, glaucoma. And these patients usually need a very large graft, which can be really challenging unless you have access to femtosecond assisted dissection. This is one of my mentors, Dr. Vajpayee, who's in Australia now. He published this 2008. So basically, you do a mushroom keratoplasty, lamellar though, and you tuck in the edges of the graft into the host bed. You can do this easily manually. If you have access to femtosecond platform, of course, it's going to be easier. It's going to save time, but it leads to massive flattening of the cone, and patients' uncorrected visual acuity improves as well. And you can fit a contact lens or even give glasses. I'm not going to discuss this, but I can tell you my experience with the combining cross-linking with refractive procedures has not been great. We actually published that these patients will lose vision at least a line for the first few months. So definitive evidence is still lacking just because of lack of randomized control trials and long-term follow-up. So to conclude, post-refractive ectasia is a rare complication today. Corneal tomography, it enables us to as you saw in the examples, unless you don't expect it and you don't do a corneal tomography, you're not going to find it. Management depends on the stage of the ectasia. Contact lens fitting is definitely always an option before surgery. If the patient is motivated, cross-linking might help to slow down the progression, and the corneal transplantation needs special techniques. Thank you very much for your attention.
Thank you, Dr. Jhanji. That was wonderful. I have a question if you have time.
Yes.
So, what is your experience with PRK with C3R when a patient is diagnosed with keratoconus?
So no, we don't do refractive procedures in diagnosed patients of keratoconus. You can try and do a refractive procedure in a borderline patient with corneal tomography. I've never performed refractive procedure of any kind in a patient who's known to have keratoconus. I'm not for it because we don't have long-term studies.
Yes, because these days refractive conferences are all highlights with the refractive procedures in keratoconus and ectatic patient. And I thought maybe if somebody has more, but the evidence are lacking in literature, of course. So I'm also not doing it, but a lot of people are advising these procedures to keratoconus patients as well.
Yeah. So two things to that. One, of course, it's entirely dependent on the chairperson, the moderators, and the audience to ask questions, like you did right now. And I told you frankly that I don't do those. The second thing is, you might get lucky, for the first few patients. So have you ever met anyone who had LASIK in 1990s? They're still very happy. So most of the patients, they're very, very happy after LASIK. And they had LASIK with microkeratome when we used to cut flaps close to 200 microns. It's really shocking that we used to do that. You see patients who had RK. I personally know people who had RK. They're very happy. They're never going to say anything against RK. So you do get lucky many times. But when you see unhappy patients in tertiary care centers, then you realize the amount of complications that can be associated, unfortunately, with some of these procedures. So it's better to play safe. One of my mentors always had the mother rule. The rule is if you can do a procedure on your mother, you can go ahead and do it on your patient. I still remember that.
Touche.
Thank you very much.
So one question.
Yes, sorry, I apologize.
Have you ever noticed that the effect of cross-linking in post-LASIK ectasia is much more than what is seen in keratoconus?
I have noticed that. We have not been able to publish that. We have only about 50 cases so far. But I agree with you, and that encourages us to convince the patient for cross-linking. And post-LASIK ectasia in pediatric cases, we don't wait for too long to document progression.
So at the first diagnosis, we should go ahead and do.
Well, at the first diagnosis, you can recommend cross-linking. Yes. They're not going to progress in 2 months. You can still wait for 4 months. It's always good to show some progression. It's not going to change your management or the outcome if a patient progresses by another half a diopter when you see them again in 3 to 4 months.
Yes. Thank you so much.
Those primary keratoconus patients, any experience with the topo-guided PRK smoothing first and then doing C3R on top of it?
No, I don't have any experience. As I said, I really don't know what we are achieving with smoothing. So primary keratoconus, it all depends on the stage. If you are looking at a patient who has minus 1.5 diopters of myopia and minus 2 diopters of astigmatism at 68, just made up a hypothetical number. Corneal thickness is 450 microns. So that is a borderline case. It's not keratoconus as of yet. You can stage and the other eye is normal. Okay, so for this patient, you might think about combining a procedure depending on how keen that patient is.
Yeah, suppose there's a loss of best corrected.
Mhm.
Suppose you are at 618, maybe 624, and you want to improve the best corrected and maybe help the patient not to be on contact lenses, maybe get rid of contact lenses. So what we are doing is that all those cases whose best corrected vision is not improving to 6 by 6, so we are doing a primary topo guided PRK. So we're trying to smoothen the surface and then doing a C3R on top of it. And we are seeing that the best corrector is almost increasing by 2 lines.
Okay, so I encourage you to publish and present your results,
That
that
already
especially the long-term follow-up. So you have to agree, though, with topo-guided PRK, sometimes the refraction can change drastically. I don't know what your experience was, and then you end up basically not correcting too much for refractive error. So the patient would still need glasses or contact lenses.
Yes, of course, with glasses. But
Yeah.
what we are only trying to do is just get him maybe off contact lenses,
Uh-huh.
and so that he has more options to maybe have a better quality vision. Plus, also I wanted to ask, any experience with intacs in post LASIK ectasia?
Sorry, let's go back to that case. So if you are smoothening and the patient still needs cross-linking and glasses or contact lenses, what is the advantage of that
That
smoothening?
sometimes you can maybe take him off hard contact lenses.
Yeah, but hard contact lenses, most patients don't use RGPs nowadays.
Yeah,
There are
yeah.
mini square lenses that are as comfortable as soft lenses. I'm yet to see patients with keratoconus who do very well with soft lenses. I mean, there are a few, but not many. Young patients do well. So ultimately, everybody needs a customized contact lens. So that's the reason we try and not take away any tissue in a keratoconus patient. So we don't have evidence. I'm sorry, we're taking so much time. So recurrence of keratoconus or ectasia is supposed to happen in 7 to 10 years. The collagen in the cornea, it sort of regenerates or reprograms itself on average at 7 years or so. So we don't know how long, if you take some tissue from a keratoconic patient doing topo-guided PRK for smoothing, we don't know what you are doing to these patients in terms of corneal thickness and their risk for progression again. So you really have to follow them up, ideally for at least 5 years, if not 7. Intacs, you can do intacs if you have a really bad cone. But again, the point is, if you're going to fit a contact lens, and intacs is going to make the contact lens fitting better, then I would go for intacs. Otherwise, there's no point doing an additional procedure.
Because what happens is that usually in our practice we see that people are not very motivated to wear those hard lenses, and usually they are looking for a solution. That is because when we counsel them initially and when we give them an option of a basic primary C3R versus combining it with a topo guided PRK with C3R and reducing the dependence on contact lenses maybe in future, so they're very convinced listening. So of course the patient selection is important. You should
Yeah.
have a sufficient thickness, and you have to see that you're not over ablating more
Sure.
than 40 microns whenever you are smoothing.
Yeah,
Yes,
definitely. And again, I tell you that 40 microns is just a number that came from New York, and nobody looked at the validity of that number. I would if given a choice, I'd rather do intacs. But you're still an additive technology, than take away any tissue at all. Those are the only papers that are published. We still have follow-ups are pretty short. All right, sorry we took more time. Thank you very much.
Thank you, sir.